Joseph Roussel is responsible for developing and applying high-impact private sector partnerships, capacities, and best practices to Village Reach's work. He is a co-author of the book Strategic Supply Chain Management, the 5 Disciplines for Top Performance, and has a wealth of supply chain knowledge and experience. Craig Usswald is the Director of Supply Chain at Village Reach and is based in Cape Town. Craig has worked in the supply chain profession all around the world and brings a strong background of supply chain experience. Ladies and gentlemen, please welcome Joseph Roussel and Craig Usswald.
Yay, Craig!
Good afternoon, everyone. Thanks for joining us. Very quickly, a slightly more personal introduction to Joseph. In the Village Reach context, Joseph looks after our private sector engagements, as well as our transition to government, 2 very important strategies for the business. After living in Paris for over 20 years, he strangely chose to move to Antwerp late last year and is now based in Belgium, and obviously spends a lot of time in Africa as well.
Thanks, Craig, for that introduction relative to my eccentric residency choices. But Craig Usswald, in charge of our supply chain technical team, which supports our country offices, joined about a year ago, and I was very delighted to have a supply chain specialist with many years of experience join Village Reach, and he brings not only public health experience, but also private sector experience when it comes to supply chain. So very much a pleasure having you join the team, Craig.
Thank you.
So I would like to start off by talking about our objectives, and I do believe we have a bold objective, which is, can you learn in the private sector from the public sector? And particularly, are there insights from the public health supply chain space that are useful and applicable to the private sector? So we have the courage to propose that that is the case, and we're hoping to share those insights with you. These insights come from our work, particularly in Mozambique and the DRC. We noticed that those were 2 countries highlighted in the risk presentation earlier. We will want to start the session by asking how many people support our hypothesis that there is something to learn from the public health supply chain space for those players in the private sector. So we're just asking for a show of hands, not just to encourage us, but to see whether you should be in this presentation or not. So how many folks believe there's something to learn from the public health supply chain space, even if you're in the private sector? So let's see some hands. Okay, I find that quite encouraging, Craig. You'd predicted perhaps an Armageddon scenario, but we didn't achieve that. So thank you very much, and we're hoping to support that hypothesis and also give you some nuggets that you can apply in your firms.
So, as you listen to what we have to say today, it's obviously important to get context. How does our business drive? What do we think about when we try and execute? One of our taglines is to say we start at the last mile, which sounds pretty insane because that's the hard part. But that's where we focus all our efforts on making sure health facilities don't suffer stockouts. We do that by making sure that we attend to health worker training, understand their needs and expectations. We make sure they have access to products as often and as frequently as possible, and obviously redesign the supply chain to suit their specific needs. And we make sure we have data systems supporting those efforts. Get as much visibility as we can in the process as possible. Again, challenging when often infrastructure such as power, connectivity is not always there. So try and make the best of a difficult situation. Where do we work? So we have 3 core countries. Mozambique is 20 years old. A few years ago, we opened up Malawi, and less than that, 2-3 years back, we opened up DRC. DRC, as we all saw from the risk assessment, difficult, challenging location, hard transportation routes, very few formalized roads, quite a hard nut to crack, but cracking it we are. We've made some big progress in system design, and that'll continue. Our partner countries is where we work in locations where the other partner has got a prime relationship with the government. When I introduced Joseph, I spoke about transition to government being very important to us. And because it's one of our key strategies, we consider a partner country where someone else has the primary relationship with government versus the relationship we have in those other countries I mentioned. This expands all the time, and obviously it goes to donor and country need. The three primary buckets of supply chain activities, although they're somewhat diverse, the first one on the left-hand side being next gen is what we call our next generation supply chains, primarily for vaccine distribution. Very, very susceptible to all the issues with fragile equipment and fragile product, temperature excursions, lack of cold chain equipment at the various junctions, makes it an interesting challenge to try and break down, makes a lot of research required and a lot of collaboration with other parties as well. Open LMIS, Logistics Management Information Systems, tries to give us the data visibility we spoke about earlier, coupled into other program and products that are serving that government's needs, and tries to get us data visibility across the board. On the other programs, we do various different endeavors, largely around 3PL transportation, hired within the country to do transportation to that last mile. We find that local knowledge transportation is a good sustainable model. We do all the relevant experimentation one needs to do with drones to get them off the ground. Obviously, trying to find a use case is the age-old challenge for all of us. It's progressing faster than one would think, and there's a lot of work going on in several locations. And finally, I'd say that one of the biggest solutions we're finding is the pharmacy assistant program, is training pharmacy assistants to be a bit more adept at supply chain type issues, showing incredible results in Malawi at the moment.
Yeah, Craig, one thing that I think is important for us to highlight is we really don't do this alone. Clearly, we're partnering with governments. Everything we do is in partnership with government, but we also involve quite a few other partners. I'm particularly responsible for involving private sector partners, whether they be mobile operators, logistics operators, but we also work with a number of other partners, and some are in the room today, so it might be helpful to call them out.
Well, I suppose you could ask the partners to raise their hands. We obviously have worked with Imperial in the past, and currently are talking to them about a few projects. Thank you, Ian. Jose, you're in, James in the room as well, Project Last Mile in Mozambique and elsewhere. Doing incredible work. Who else can you see in the audience?
Last Mile Health, but they're not here, I think. You're working with Last Mile Health.
Last Mile Health in Liberia at the moment as well. Obviously collaborate strongly with ASCM in their various endeavors, working with ARC in trying to dovetail and conceptualize what they're trying to do as well in collaboration. So, and probably many that I haven't mentioned because I just can't see you in the slide program.
Yeah, I thought it was kind of important to highlight we really are working heavily with partners, and we really rely on them to develop and implement sustainable solutions. So thanks, Craig, for that extra. So we're going to talk about the last mile, and I actually heard this term bandied about quite a bit this morning, the last mile. And one thing that's quite perturbing, I remember when supply chain management first off the ground, there were 500 definitions of supply chain management, but I'd say there are probably just as many for the last mile. So before kicking off on our discussion, because we're really going to be talking about what we're doing at the last mile, I thought it would be a good thing to talk about what do we mean exactly. So Craig, maybe some reflections on different definitions of the last mile before we actually get into what does it mean specifically for health.
So the irony of the last mile is that when Village Reach was founded 20 odd years ago, the name was coined from someone in distribution of electricity and power. And for them, the last mile was that last bit of distribution that actually reached the consumer. So that's where the entire phrase came from. But obviously, as we see Amazon and others migrating towards their customer, starting to put manufacturing and distribution facilities at the last mile, you could say that the last mile is each sector's representation of their final chain of custody before they actually hand it over to the consumer. So the last mile changes depending who you are. Sometimes it's an hour away, sometimes it's days away. In our world, right now, the last mile goes to health facilities, but equally right now, it's starting to go to consumer, community health workers and community health worker assistants. Different governments have different perspectives on where community health workers fit in. They're a very integral part because they get right into the villages and into the fabric of society. They end up doing quite a big job for the second infirm that can't get to facilities themselves. So we do see the last mile going more towards patient-centric treatment and patient-centric delivery. And who knows, in the not-too-distant future, you could find international locations packing scripts for people and delivering to a village to a patient via some community health worker.
Thanks, Greg. And maybe a drill down into what we're calling the last mile in extreme environments, because we really are dealing with extreme environments. I guess a lot of people, when they think extreme environments, they're thinking about the road system, because that's kind of an obvious a representation of extreme environments. But I think, Craig, as you said earlier, for us, it's really wherever the patient or the customer is going to get care or medication. And that can be in many different places. And I'm very encouraged by what you said earlier, which is we're moving more toward a patient-centric approach, which is where does that patient able to go, want to go, versus what can we actually do today? So instead of starting with the supply chain and saying, how far can we go, going out and saying, where do we need to be to actually get to the customer or the patient? And that patient-centric, customer-centric approach is starting to permeate thinking in public health, which is great. But going back to what we mean by last mile in extreme environment, as Craig pointed out, isn't just about roads. It's about infrastructure. Does a health facility actually have working fridges? Does it have personnel who've been properly trained in inventory management? And it's also about electricity. So we are working in those environments, and we are hoping that through the practice of implementing workable systems in those extreme environments, we'll be able to squeeze out some insights for you today. And Craig insisted that I add this to the presentation, that when we're working in a country, there are not hundreds, but often thousands of locations. So the question isn't, how do I make it work in 10 health facilities? It's how do I make it work in 800 health facilities? So one of our challenges is coming up with sustainable solutions that are scalable, because just doing something that works in one province is not really proving anything. So the scalability consideration from a supply chain perspective is also critical. And I'm sure that many of you who've implemented supply chain transformations in your organizations or helped organizations do that have come across this concern as well, which is we need to be able to scale the solution. And when we're talking about scaling in extreme environments, we have a lot of considerations to bear, and those we will be looking at. One question we wanted to ask the participants at this stage is, who actually wants to grow their presence in these bottom of pyramid extreme environments? I mean, how many have that ambition? And we're interested, just if you could raise your hand, how many actually want to do more in those environments? Could you raise your hand very high? Okay, because you really are our core audience for this presentation. The others who didn't raise their hand are welcome, but we really think we can satisfy those who raised their hands today. At least that's our humble aim today. So let's talk about the last mile challenge. I think in health, it's quite dramatic, and it's to do with people's lives. It's not just about getting medicine or a well-functioning health clinic. It's about doing it consistently. And what we find and this is a photo of work we're doing in Equator Province in DRC, what we're really finding is, are we actually creating a promise that we can keep with the patient or the customer? Because it's clear if they have to come from miles away to see a health practitioner or to get a medicine, and the health practitioner isn't there and the medicine's not there, after a while, they're not going to come back. So building that confidence in the system, the confidence that's necessary to have a customer/patient come to the health facility, listen to the advice they're getting, that's really what we're about. And it requires consistent delivery, not occasional delivery. And in some areas, we are rebuilding that. You know, where the public health system, the health facility has failed to deliver that level of service, patients/customers just don't come anymore. So rebuilding that confidence, and I'm sure if you're in the private sector and you're in retail, you have the same issue. If you advertise to the market that you're running a special and they come and the product's not on the shelf, they're not going to keep coming to the store for those specials. And eventually they're going to start saying, how can I trust this retailer who 1 week has the product on the shelf, 1 week doesn't? And so it's a basic question between a customer and a retail location. And we're in front of that same challenge, but the problem is greater in that we're actually dealing with people's health, if not lives. So that's the dramatic challenge that we're faced with when we talk about the last mile challenge. It's actually building up a system that citizens can have confidence in and will be going to for care and medication. So we're now going to go into the 3 case studies, and I didn't really dwell on the objectives at the beginning of the presentation in terms of the particular learning points, even though we're often told when we give a presentation that we should tell people what we're going to say, tell them what we're going to say, and then remind them of what we said. But I've skipped the first step, so probably because I felt you might have had information overload pre-lunch, but we are now going to go into 3 small cases. Now, each case will give an overview of the issue we are working on or have been working on, but then we're going to do a drill down into a specific point which we think will be applicable to the private sector. So each case will more or less have a similar structure. We'll give an overview, we'll talk about what was done, and then we will go into a very specific drill down on 1 learning point per case. So Craig's going to kick us off on the first case study.
On the system design approach, there's 2 fundamental ways we try and uplift or change or improve a supply chain situation. You can either do a full system design diagnostic, which is at times disruptive, can use a lot of resource, but does give you a good end result in that it gives you an end-to-end visibility and allows you to assess where the optimum opportunities are to improve. The alternative way is, of course, to react to pain points that people might be experiencing in their supply chain. Do you have a stock out? Are you overstocked in certain places? Are you traveling too long a distance? What are the real issues you're suffering? And those are a different way of approaching it, but you do get some quite quick wins out of that. In this particular case, the brief was to do a full system design approach for the supply chain in Pakistan. In the beginning, we focused on vaccines. So the biggest reality we uncovered was that vaccines were traveling inordinately long distances because the approach that was chosen for storage in quite a vast geography was central and national. So all the product came into a national location and then traveled all the way back to those 2 large provinces on the bottom left. And the travel distances were so vast that there were a lot of temperature excursions for the product, a lot of spoilage and wastage was taking place, and therefore, irrespective of what was bought, you weren't reaching all of the patient potential. Okay. Looking at that centralized model, we obviously discovered that vehicle distribution distances were suboptimum. Costs were fairly low on the point of view of total cost imported because of aggregation and consolidation of loads, but ultimately pretty high per unit because there was so much wastage and the ultimate per unit cost rose quite high after that. Supply chain structure was a single point of entry, as I mentioned earlier, very much a national distribution system. The centralized model was obviously chosen by the country. It was what they had, they knew no different. So we had to look at what the other options were. Cyclically in business, we've all seen over the years, the longer a business is around, the more cycles it goes through. And any business with multinational or even national but multiple footprint locations, depending who the management team is, goes through a centralized versus decentralized cycle. It's just one of the natures. Some new guy comes in and says, what can I do differently? If it's centralized, they say, well, what about decentralization and vice versa? So we see this happening a lot. But in this particular case, the decentralized model bore a lot of fruit. Understanding that a couple of provinces could in fact receive their product directly would significantly cut down the distribution distances and therefore make the product a lot more efficient all the way through. So it was a hybridized model of saying, stay with the national control, but for these two provinces, let's build up their capability of doing inbound transportation, clearing and forwarding, and let's get that handling to be reduced quite dramatically. And that was ultimately the study that demonstrated that there was a fairly good option to think of as an alternative. So the requirements, obviously, were to reach patients in a successful fashion, to make sure that the product stayed true to its performance requirements, and ultimately, all round, just reinforced everything we'd seen that was right about the decentralized model. Several different approaches we could have used. Get the next slide. But ultimately, the chosen approach was that reducing handling frequency and distribution distances was clearly the answer to use. The trick was, of course, from a change management perspective, getting those provinces to behave autonomously, which they had not had a chance to do in the past, and doing a lot of change management, getting them trained up to the position where they were ready to do that new work. All round, quite a big departure from them for the country as a whole, but ultimately a really good end game with some good results.
Craig, just a quick question. You mentioned at the beginning of the presentation, and I guess that's the title of this case, you used a system design approach. So could you talk a little bit about why you picked that approach to solve the problem, and perhaps what you think the private sector could learn from that approach?
I think looking at the options available to you that are not necessarily always cast in stone as you might think, looking beyond potentially the scope and mandate of what you've been given a brief to do is always going to reveal opportunities that you might not have otherwise seen. Don't accept the mandate to be ring-fenced around a certain area that you normally work. We normally work at the last mile. It was anticipated that we would only do last mile recommendations and only last mile fixes. We would improve handling, we would improve the cold chain, we would probably improve the way they handle the product at the recipient health facility. Going out of that box, going to inbound transportation was something we just had to do to finish the final outcome. So we're recommending, again, to yourselves, irrespective of what you think you're allowed to do, just challenge the paradigm a little bit further, because oftentimes that's where the solutions lie.
Thanks, Greg. And we will be at the SAPICS booth, I believe, during the coffee break. So if there are more questions about these case studies, don't hesitate to come see us. So I'm going to go into the second case, which is about Mozambique, and I'm happy that our Project Last Mile partners are here with us. I'm sure that I'll get nods of approval or disapproval, depending on if I go in the right direction. But what are we talking about when we say frugal approach to supply chain technology? And I'd like to define a few of these words. So by frugal, I think you probably noticed in the political risk assessment presentation we had earlier that a number of governments are highly indebted. And high indebtedness means low amounts of money available to finance public services, including health. So generally, by frugality, what are we talking about? We're talking about spending just enough money to get the functionality we need, not more than what is needed. So it's not about cheap, it's about just enough. So that's what we mean by frugal. And by supply chain technology, we're going to have a particular focus here on vehicle tracking systems, proof of delivery systems. Basically, how do we know that the commodities actually got to where they were supposed to? So that's the technology focus we're going to have in this caselet. So the work that we have been doing and are still doing is in Tet province, and I think you can see where it is in Mozambique. When we started there, we started because Tet province was one of the few provinces to immediately say, we want to try something different. We're interested in working with the private sector, whatever it takes. We need to improve medicine availability at the health facility level. They basically did not have sufficient transportation resources and the capacity to maintain those resources to ensure regular deliveries to health facilities. Fortunately, the national strategy promulgated by the Central Medical Store was very clear in terms of what the ambition was, and that did include the use of private sector transportation. So we took advantage of that opportunity to actually go into Tet province and work hand in glove with the DPS, the health authority of the province, and really start looking at how to change things, which included finding private sector transporters that were in the province. And then really looking at how we might change the way they were working, because I don't know if you're familiar with this, but those in public health probably are aware that very often different medicines are delivered at different times of the month because there's quite a verticalization of health commodities and the way they're treated. So we wanted to bring those schedules, which meant the forecasting schedule, the transportation schedule, into alignment so we could put as much medicine as possible together in one truck. And that also meant changing the warehousing practices and then really building trust between the private and public sector. The DPS had never really worked in a systematic way with the private sector. The private sector hadn't really worked with the public sector either. So really building that environment of trust was critical. In terms of the major changes made, I've talked a bit about the old model. We've talked about the multiple supply chains. I didn't talk about the multiple tiers. There were medicines going from province to district to health facilities. We implemented a direct distribution from province to health facility. But generally, there were a lot of changes that needed to be made in terms of operational practices and then fundamentally managerial habits. In terms of the new model, in terms of what we put into place, the 3PL firm, which is a local firm, we have two of them working for the DPS, they actually have full responsibility for vehicle availability, vehicle maintenance. We are able to deliver systematically on a schedule every month to all health facilities in the province. It's true that it costs more, but they weren't actually spending the funds, so it's hard to say it's expensive, but we can say, of course, more money is being spent. But we're also working on cost efficiencies now because we have the data to understand how much is being spent per route, how much is being spent per month, what is the difference between the rainy season and the dry season, so we have that information to do the optimization. And I mentioned earlier the combined deliveries, which is an absolute critical thing. Teaching the DPS that the more commodities we can actually get into one shipment lowers the cost of, it didn't take them long to understand that. They became very motivated to promote cross commodity distributions. So quite a few changes made, and we're very pleased with this particular implementation in that we're now in the process of handing this over to the DPS to actually manage themselves. So Village Reach, as Craig mentioned earlier, we're very adamant about developing capacity for government to manage solutions. As you can see from this example, it doesn't mean they do everything because there is space for the private sector, but they need to take over management. An NGO such as Village Reach should not be in the business, we believe, of operating supply chains. So we're really actively in a process now of handing this over to the DPS in the province, but also bringing in the central government entity that'll take over some activities that are more infrequently done, such as costing, route optimization, and we're very happy Project Last Mile is working on capacity strengthening at the national level because that kind of capacity is also going to be needed to work hand in glove with the provincial DPS. So those are all the things, but what is this case really about? Let's come back to frugal approach to technology. Did I mention earlier the issue of government confidence? So all of a sudden, their medicines are not going out in their vehicles. They're going out with these private sector partners. How can we increase confidence? How can we increase visibility? Well, we really need to know things like, did the truck actually go to where it was supposed to? Did it actually arrive when it was supposed to? So some of the requirements. Can we optimize? Do we know whether things were actually delivered? Do we know how much it actually cost? So we need to be able to have visibility. And I'm going to say we, I mean, I'm the DPS, I'm the government, I want to know what's going on, what's happening. So how are we going to do that? Well, we need technology. We could actually stay with the existing paper system because there's a lot of paper documents floating around. We could have basically told the transporter, no, just fill out this paper form and bring it back and we'll be fine. But that really wouldn't have given us the ability to optimize. It wouldn't have answered some key questions like, did they go when the clinic was actually open? Because let's be honest, before we implemented the vehicle tracking system, we were getting reports back that medicines were being dropped off at places out of hours. Health facilities closed, opening hours were not respected by the transporter, or the transporter didn't come. So all of these issues did not create trust. So we really needed to not only have an environment of trust, but be able to optimize. And Project Last Mile has been very helpful looking at route optimization and how we can actually do better in terms of kilometers traveled. Where is that information going to be gathered? So we actually need some technology for optimization as well as trust. And we did look at different technology options, and our choice was really to use one system, which is a vehicle tracking system, just one system. And by triangulating and getting data out of the system, including when they visited, how long they were at the facility, we know that if they only were there for 10 minutes, they did not do a delivery. So we basically cover with this system the key conditions that allow us to, A, say, job done, B, job well done, and C, a basis of fact. So at the end of every month, when there's a performance review between the 3PLs and the DPS, they actually have data that they commonly agree on and can actually work off of. We decided not to implement a modeling system because that would not have been very effective to give the province a network modeling system. That's something that needs to be done nationally, and the PLM team is working on that in terms of creating that ability nationally. Also, implementing yet another proof of delivery system on top of this wasn't necessary. So what we've basically done is figured out how to take the one system and use it for multiple purposes. And for us, this really is a win for the government for two reasons. One is this system is not dependent on any particular transporter. The government can procure this independently of any service contract. And second, we've been able to negotiate extremely competitive cost for this system. And we believe that this is a good approach for Tet Province, but it's not what we think. It's when you interview the head of the DPS and he says, I can now see what's going on. We now have data that we agree on with the transporter. And what made me even more excited is when I was in Tet Province on the last visit, one of the managers of the 3PL said, I really like this system because I can better manage my fleet using this system. So we're really seeing an upskilling generally, not only in government, but in the private sector, but by using a very focused approach to technology. So that's the case.
Before you move on, share why you think the private sector could benefit from this, but equally, just expand a bit more on the transition to government framework and what we're trying to achieve from the outset.
Yeah. Thanks for the question, Craig. I really think that this question of frugal approach to technology is fundamental to the private sector as well, because we have so many solutions out there. There are so many specialist applications. I mean, you could literally implement 5 or 6 applications. And what we're seeing is in environments where they're very low resource, there's very little money to spend, we can't have it all. We have to make some trade-offs. We have to make some decisions. And I think that when you're addressing this market where the margins may be thinner, but where you really need to look at your cost structure because you will need to pass that on to the consumer, how do you do that? And we think that this is an area which is ripe for that because very often in perhaps higher income markets, we're able to implement many more technology solutions. I believe, and we believe that in these lower resource environments, it's really important not to go for a suite of tools that scratch every itch, but really find a solution that covers the majority of need and above all, provide absolutely obvious benefits to the users. In this case, government plus the private sector. And on transition to government, we really know that we cannot transition to government something that government can't actually understand and manage. And this type of tool is something that actually provides them with an understanding of what's actually happening and some facts. So they can have discussions with the private sector based on facts and not perceptions. I don't know if I answered your question.
Thanks.
Greg. Okay. So frugal approach to supply chain technology. I'm looking around the room. We'll be talking over the break, undoubtedly. And I'd like to take you to the third caselet on an integrated service model in the DRC. So what do we mean by integrated service model? So this is a concept that probably any logistician in the room could probably lecture me on, but integrated service model means we do more than transportation when we go to a service delivery point. By service delivery point, that could be in the private sector a retail outlet, in our world, it's really the health facility. So we're calling each health facility a service delivery point. As Craig said earlier, that could expand to a community health worker's address. That could expand to other locations, but I'll be mostly talking about health facilities. So by integrated service model, we're really talking about what are all the things I do when I make a delivery? How integrated should it be? How disintegrated should it be? And we're talking about work that's done by our DRC team, led by Moto Etomoke. And we were just on the phone the other day talking about the work in Equateur, which is a really challenging province. I don't know how many of you have been to Equateur province. Could you raise your hand? Has anyone been there? Imagine a mostly river-based transportation environment. So most goods are being transported up through the Congo River. The road infrastructure is fairly limited. So it's a challenge. And what we are working on here really is figuring out initially vaccines, but we added other commodities to that. What was going on, the medicines were being delivered to the province and health workers were coming to the province, or actually district. So the medicines would go to the province would distribute them, but health workers would have to close their clinic and go and pick up these medicines. So they were just not available to take care of patients. And then the actual maturity of practices at the health facility level was fairly low in terms of inventory management. And as Craig pointed out earlier, one of the typical features we see in a lot of countries, cold chain equipment, not just not functioning, but sometimes absent. So there were really missing infrastructure here. So really the question was, how do you get medicines on a regular basis to these health facilities? But above all, how do you make sure these health facilities actually have the capability required to manage the medicines once they're there? So it's really not super helpful to deliver a medicine to a health facility when it's not going to be managed properly. So these were the concerns and questions we had as we started working, and that was well over 2 years ago in Equateur province. One question I've been asked a few times is there are 284 health facilities and 18 hospitals. Why were we working in 41? Here we actually started in 41. We're currently expanding to others, but it was felt by the provincial government that already if we could demonstrate to the public workers that this would actually make a difference, that we would get the buy-in required to actually implement a different approach. So I'd like to talk a little bit about the new model. So the new model, we were using private sector vehicles, but actually renting them. We did implement the model you saw in Mozambique, which was level jumping and going directly from province to health facility, which was a major win. As I mentioned in the Tet case, the Tet province case, once again, grouping commodities as opposed to having multiple deliveries to a health facility, which isn't only just more expensive, but imagine if you're a health worker and you have to stop and do goods receipt every time you get a new delivery during the month. So that's quite, and I've seen in Tet province, there's a line of 50 people waiting to get medicine. The last thing you want to do is stop and do another goods receipt, while you're in the middle of dealing with patients or customers. So in terms of the requirements, it looks very much like the previous example in TET. We needed to transport product on a predetermined schedule. We needed to collect information. We needed to make sure that, and I didn't mention this in detail, but we'll come back to TET. We needed to make sure the inventory control was in place, that the cold chain was working. We had a number of requirements. So we looked at some approaches, and I was actually brought into a discussion with Project Last Mile. I don't think Trip Alport is here, but Trip came to Kinshasa. We sat down with Heineken, actually, and said, we have this issue, which is we need to get medicines transported in a very difficult to access province. What do you do in Equateur province? So we sat down with the Heineken team, and we really determined that their distribution model was primarily to province, and then private sector distributors would come and pick up in the provincial capital. They would come and pick up the product, and they would take it out there. So we figured out that actually we unfortunately couldn't follow that model in terms of leveraging private sector. We did a private sector study to see what the private sector was out there. We also considered just getting DPS employees, public sector employees that knew skills development and inventory management, get them go out to the health facilities and deliver. And we said, why not also have regular visits by cold chain technicians? So these are different approaches we were considering. And when we looked at everything and the cost of it, we really realized that we actually needed to get a person, just one person, to go out and do everything. So we basically said, look, we're going to take that DPS person who previously was primarily focused on capacity development, and we're going to train them and upskill them in terms of not only product delivery, but also collecting the right data and training on site the health workers. And this model has proven to be extremely effective. And it comes from two realizations. One is there is not the private sector capacity to do those types of things. And I didn't mention, but in TET, we've actually trained the 3PL. The 3PL doesn't just do medicine transportation. They collect cold chain information and inventory information. So we actually have trained that 3PL in Mozambique, and that's the model we're promoting in Mozambique, a 3PL that has multi-skilled capacity. In Equator Province, we actually couldn't find transporters of that capacity. And we looked at it and said, is that really the right way to go right now, trying to develop those 3PLs? And we also noticed in terms of incentives that if we deprive all of the DPS employees of a source of revenue, which is constituted of different elements, including their per diems, would they really support this model? Is that economically wise to take an employee that you desperately need because they have capacity development, and that really do need to be compensated in terms of the time they're spending? Is it really wise to take them out of the equation? So looking at both the supply market and the essential role of the DPS employee in capacity building, it became very clear that we needed to put more skills into that DPS resource. And that's what we've done, and it's worked really well in terms of medicine availability, which has increased dramatically in those health facilities. So for us, this integrated service model took us in a completely different direction than it did in Tet Province, but it took us to the right place for the DRC and for the Equator Province. And I think this comes back to what Craig was talking about, but we also saw it in several presentations this morning, which is we really need a more customer-centric approach. And that starts with going and understanding the actual context of the people you're serving. And until you go out there and actually work with them and figure out what's out there, you're not going to develop a good solution. And this explains why the solution is quite different between the two provinces. So our notion of an integrated service model is quite different for the DRC, but it's working quite well. Greg, any?
I think the private sector lesson here is maybe a little bit less obvious because of the nature of the limitations in the country. So maybe you'd like to just expand on that.
Yeah, so we had a number of people raise their hand earlier when I asked how many of you want to increase your activity, revenue, presence in the lower income markets, base of pyramid markets. So quite a few of you did raise your hand and say you wanted to do that. And where I think this is particularly applicable is the starting position for many private sector players is more or less extrapolating what they're doing today into that new segment, or simply saying, I just need to take what I'm doing now and cost reduce it. And what we've actually learned from the work we're doing in these more extreme environments is that really would not work. It really starts with just going to the environment, working in it, understanding it, and then designing from the environment back out. So really designing a supply chain through intimately understanding what's the reality of that environment. Because if we would have taken into DRC what we were doing in Mozambique and said, hey, we have a model in Mozambique, let's just apply it in DRC, it would have been a complete failure. So I think for the private sector, the question is, if you're really going into a segment which is a lower resource segment, what we're calling extreme environment segment, low resource, what are you thinking of in terms of supply chain? What are you thinking of in terms of processes, in terms of tools, in terms of organization? Are you thinking about taking the transporter you have now and just getting them to do what they're doing today? What we've learned is you have to really question everything you know based on a real insight you gain from going to the environment. So I'm hoping that'll be applicable to the private sector participants today. Just thinking, questioning how to go to market in that segment.
We often muse in the consulting arena that countries and circumstances and companies think that they're unique and they're different, but really they're pretty similar. So why don't they just take the solution we want to give them? Clearly, this is good proof positive that it isn't always the case. If you're sitting in America, which I have been for some years, and you look at Africa through the eyes of CNN, you have a very different reality to what it really is all about. Equally, if you hear the reports of what goes on in Ecuador province, you might go there with a cut and paste solution, just want to get it done as fast as you can. But when you're faced with those realities, you've got to reinspect your departure point, reinspect your destination, and say, guys, how can we do this really effectively? How can we conceptually adopt things that the country will A, accept, B, be willing to work with, and C, could be sustainable as well. So all those factors have got to be in your mind as you enter these environments.
Thanks, Craig.
So let's recap very quickly on each of those areas. I'm going to stop with system design, obviously. The biggest thing about the African market at face value is that many of the infrastructural setups were set up often decades ago. Since they were set up, different disease profiles have emerged, different levels of funding have emerged, different levels of road networks have evolved, and suddenly the location of the facility vis-a-vis the destination points is not always optimum. There's often multiple levels of infrastructure. You can go from central medical store to provincial medical store to district to zonal to health facility. Then you add in the complexity of the community health worker. So sometimes a system design approach holistically, where you go and model what the system design program looks like, you enable the country cohort themselves to become adept at analyzing that model, putting new input data into it, seeing what the model spits out as being the best optimum way of rerouting or changing the network. It's also obvious to all of us in this space that if you change fundamentally your supplier base by any decent percentage, even that is going to adapt your model to being maybe more efficient if you did something different. So a modeling tool is great if you can A, populate it with good data, B, consult it regularly, and C, respond to the results it gives you. If you're not going to do that, or you don't think they have the capability, probably don't do system design holistically. But back to our Pakistan example, look outside the box of what you're given to work with. Look beyond your ring-fenced perception of where you should be seeking a solution, because oftentimes it sits outside that.
Craig, you want me to go to the...
Please do.
Yeah, so I've just hit the frugal approaches and the customer-centric thinking. So maybe just to like a wrap up, because it's always great to finish early, especially after lunch. I think if you look at everything that Craig and I have humbly tried to share as applicable to private sector players, our thinking is that supply chains need to be efficient, but they also need to be customer-centric. And we don't think those things are contradictory. So that's, if I could leave you with that idea. Customer-centric and efficient are not contradictions, and we think supply chains, particularly at bottom of pyramid, need to be both. The other idea that I'd like to share with you is that you're going to need to be creative. And I think I said a few minutes ago, don't project what you're doing now to these environments. You really need to think through it, and I think we've illustrated 3 ideas. One is a different approach to designing supply chains. We've introduced the idea of unconventional uses of technology. I wouldn't say strange, just unconventional, because we're using systems to do more than they're typically used for. And then finally, maybe using supply chain partners in ways that you haven't used them before. So instead of saying, hey, it's a transportation firm, maybe you need to give them some unconventional roles to play to make that supply chain really operate in that difficult to access environment. So we're hoping those ideas will be useful for you. And Craig, that was all I had to say today.
I think one potentially counterintuitive thought as well is that don't try and innovate for the sake of innovation. Often we go in there as perceived experts and we think, what's the next innovation going to come from those guys? And often the client is leaning in that direction as well. Sometimes innovation is the furthest thing from the solution. Sometimes being back to basics actually works better in that environment. Innovation, when it's got all the infrastructural support that it requires of connectivity and power and education levels to understand what the full power that could bring, then it's worth pursuing. But innovation for the sake of innovation can probably be more of a disruptor than an enabler.
Okay, thanks, Greg.